You're listening to Be Health Connected, a podcast by the St. Louis Area Business Health Coalition. Your host for today's episode is Dr. Kelsey Hannon, BHC Director of Research and Analytics.
Hello, I'm Kelsey Hannon, Director of Research and Analytics at the BHC, and welcome back to the BHC's Be Health Connected podcast. Today, we're discussing chronic kidney disease, or CKD, the impact that CKD has on the American workforce, and how employers are uniquely positioned to help prevent late-stage CKD by increasing employee awareness and education and encouraging their employees to seek appropriate care for early identification. CKD occurs when the kidneys have been damaged over time, impairing their important functions in our bodies, such as removing waste and regulating blood pressure. More than 1 in 7 adults in the US are estimated to have CKD, and about 9 in 10 people have CKD but do not know that they have it. Kidney disease can significantly affect quality of life, lead to other serious comorbidities, and can be incredibly costly to treat, making it an important issue for employers to tackle. To provide insight on this topic, we are thrilled to be joined by Elizabeth Montgomery, the National Vice President of Clinical Practice Innovation and Population Health with the National Kidney Foundation. Elizabeth, thank you so much for being here.
Thank you for having me. I'm really grateful for the opportunity to speak with you about this.
Fantastic. Would you like to kick us off by telling us a little bit about your background and the National Kidney Foundation?
Absolutely. Who wouldn't love to talk about their background, right? So I am sorry to say that I'm not a clinician. I am actually someone who has a background in strategic program development, specifically in the arena of closing gaps or identified gaps in care. I have the privilege of being one of the co-founders of the Society to Improve Diagnosis in Medicine. And I came specifically to the National Kidney Foundation to address the problem of chronic kidney disease testing and diagnosis in primary care. That, as you mentioned, there is a significant population of people, greater than 35 million Americans with chronic kidney disease. 90% of them are not aware that they have it. And there are simple solutions that we can advance to close those gaps. And so that's why I came to the National Kidney Foundation, and that is the focus of my activities at NKF.
Fantastic. I think I didn't know that about you, that you started in a strategic role and weren't a clinician. Thanks for sharing that. I already kind of introed into the estimated people that have CKD and those people that don't know about it, but could you provide us with some background on chronic kidney disease, how it's treated, and then what the prognosis looks like?
Of course. So chronic kidney disease, first and foremost, is asymptomatic when it develops. So most of the 35 million plus people in the United States that have chronic kidney disease aren't symptomatic. They aren't aware. Kidneys don't cough. So they are relying on their healthcare providers to help them understand that it is present. Chronic kidney disease is generally a downstream consequence of diabetes and hypertension. There are guideline recommendations for the testing of chronic kidney disease. 2 widely available, inexpensive laboratory tests diagnose chronic kidney disease. Only about 20% of people at risk for kidney disease, those individuals with diabetes and hypertension, are actually tested for CKD on an annual basis. So you have an asymptomatic condition that is not being routinely tested for breakdowns in its diagnosis, which means that the number of therapies that are available for its treatment aren't employed as effectively as they might be. So there are some tried and true therapies to slow chronic kidney disease progression. So you'd be talking about ACE inhibitors or angiotensin receptor blockers. I should say that lifestyle and diet can play a significant role in the development and progression of kidney disease. So in the absence of a diagnosis and awareness, there's limited individual engagement in what can I do. And then the good news for all of us is that there are some game-changing new interventions that have been demonstrated to slow chronic kidney disease progression and reduce its associated cardiovascular risk by as much as 30%, which is absolutely astounding because it means people can live with chronic kidney disease instead of dying of the consequences of it. And I think it's important to note that chronic kidney disease precedes end-stage kidney disease or kidney failure. So when people think about chronic kidney disease, quite often they think about what end stage will look like. The reality is that most people with chronic kidney disease will not survive to end stage because once chronic kidney disease is present, it amplifies someone's risk for a cardiovascular event or cardiovascular related mortality like a hockey stick. It's significant impact. And so when we think about these treatments for CKD, what we're really looking at is, yes, it's important that we prevent progression into kidney failure, but it's more important right now to reduce that related cardiovascular burden on your employees and their families.
Right. So it's not just about the kidneys, but it's also about how that's impacting your heart and your lungs. And those bigger picture ideas that I feel like we tend to think about outside of end stage kidney disease.
Absolutely. And, recognizing, because, you make a really important point, is that these problems, hypertension, diabetes, kidney disease, sort of feed off one another. And that impact is amplified if it's not managed effectively. And, regrettably, if you look at the data today, it suggests that most people with kidney disease are not on medications that would optimize their outcome and slow their progression.
So there are so many important nuggets in what you just said. And I think, can we hone in on employers for a second? So if you were specifically talking to the employer population, for example, on this podcast, what do you want employers to know specifically about chronic kidney disease and how it affects their employees' health and productivity?
That's a great question, Kelsey, because individuals that are in a commercial plan, right, are much younger than individuals in Medicare. And unfortunately, because the prevalence of kidney disease is so high in a Medicare population, that many people perceive kidney disease as an older person's problem. So the Medicare population, you would see about 30 to 35% of people with some kidney impairment. That being said, in a commercial population, you will be looking at roughly 10% of your employee population having chronic kidney disease. And what is important to know about that is that individuals who develop CKD young, right, less than 50 years old, generally have a more rapid progression and a more aggressive type of kidney disease. And so when you think about the implications of this, and you consider that the average age of a dialysis start is 62, that suggests that 10% of the kidney disease population that has that more aggressive development of kidney disease is actually burning through a lot more resources in a commercial population than people realize, particularly if the average age of a dialysis start is somewhere in the early 60s. So I think that is important to keep in mind. And I also think from the perspective of productivity, there's 2 points that I'll make. One of the important things that an employer should know about chronic kidney disease in their populations is that the majority of people at risk for CKD are not getting urine albumin creatinine ratio testing. Only about 20% of people at risk get that test. Why is that important? Well, having albumin in your urine, having albuminuria, is an early sign of chronic kidney disease, and that can present before the laboratory test that shows that your kidney function is declining actually indicates that there's a problem. So this UACR testing is sort of like the canary in the coal mine as a way to identify those individuals in a commercial population who are likely the individuals that have the type of kidney disease that warrants immediate attention. And just an example of some of the work that the National Kidney Foundation did in St. Louis that sort of supports this idea is we worked with a federally qualified health center in St. Louis to deploy home testing for chronic kidney disease, specifically urine albumin creatinine ratio, this UACR test. And we mailed tests out to a large population. We got 1,500 people to complete the tests. Half of them had evidence of albumin in their urine. Half of the individuals that had albumin in their urine were less than 60 years old. So there was clear evidence, right, of the value of having this information in terms of getting your arms around who really needs attention. And there's also evidence that if someone has this type of test in their electronic health record, that the likelihood of them receiving treatment increases significantly.
Wow, that is just absolutely striking. And I think that that project, like you said, is a really fantastic example of what the National Kidney Foundation is doing, especially in St. Louis, but nationwide as well. And I think that for those individuals that that received that test, and then you were able to identify, how did that early screening impact the treatment and the outcomes for those individuals with CKD, as opposed to maybe, I guess, until they were older and already experiencing some of those symptoms?
So with the specific pilot that we did in St. Louis, we are all about not testing for testing's sake. And so we orchestrated this testing model through a federally qualified health center. We got the health center on board to ensure that there was no clinical inertia, right? Keep in mind that right now there's a great deal of clinical inertia around kidney disease in primary care. So we onboarded the federally qualified health center and worked out a care coordination model so that anyone with abnormal test results received care coordination into a conversation with their clinician, confirmatory testing if it was required, and then ideally a treatment plan. And what we were able to realize in this project was that we got almost 600 people in to see their clinicians within 6 months of the initiation of the pilot, which is a really efficient way to kind of get your arms around what's happening in the population and ensure that they get care. We don't yet have information regarding outcomes, but as I said, there are a number of papers that we can provide to support my comments today that illustrate complete CKD testing is associated with increases in use of novel therapies, ensuring that blood pressure and glucose are managed in people where it's appropriate. Lots of opportunity that has been demonstrated in larger studies to say that this testing in the electronic health record matters.
So I guess in an ideal world and in the screening that you're talking about, so complete CKD testing, what does appropriate screening for chronic kidney disease look like? And then how has the screening recommendation changed in recent years?
The screening recommendations for chronic kidney disease are fairly straightforward. It is that anyone who is at risk, so that would be someone with diabetes, hypertension, over the age of 60, someone with a family history of kidney disease, should receive a serum creatinine with eGFR and a urine albumin creatinine ratio test annually. And as I mentioned, these tests are widely available and relatively inexpensive. To your question regarding has the recommendations changed recently, there is a new test that is called cystatin C, which is now available and is recommended for evaluation of kidney function in certain populations. It is a cystatin C, while it is available, it is not necessarily available in every laboratory, and it is significantly more expensive than serum creatinine. So the recommendations stay if someone is being screened for kidney disease that you use a serum creatinine with eGFR and a urine albumin creatinine ratio. And if there is evidence of chronic kidney disease and someone has, for instance, amputations or is obese, then the consideration for using this more expensive, more precise biomarker is warranted.
That makes sense. And I guess as a follow-up, if someone is listening to this, like how can, as a patient or as someone with a loved one that they're a caregiver for, how do our listeners advocate for proper kidney screening for themselves and maybe their partners? And then as an add-on, are there specific questions that you would recommend that they should be asking?
So the first thing I would suggest is that the National Kidney Foundation has an awareness campaign called Are You the 33% campaign? And there is a website, A Minute for Your Kidneys, that is associated with it. I would suggest anyone who's interested in learning more, go to that website because there is a fair amount of information on that website answering basic questions regarding kidney disease, as well as offering materials that can be printed and taken to the doctor, or questions that you might want to have available in your phone. I think one of the challenges that the National Kidney Foundation is working to address is ensuring that the clinical community, which at the moment right now is not testing people the way that we would like them to be tested, may require some nudging. So going into that office visit with materials that are printed out or on your phone that says, yes, I have diabetes. Yes, the recommendations are I should be tested. Can you please let me know if I've had this test, what this test suggests, and what the next steps might be around that would be the questions that I would ask. Now, I think it's important to again mention that many people with kidney disease have information in their electronic health record already that is not being responded to. So, having materials that you can help you advocate to get your clinician to give you the information about both tests is, I think, really important in closing that gap for yourself. Does that make sense, Kelsey?
Yeah, it did. And I think since partnering with NKF, I've just poked around on your website a bit. And even for myself, it was really helpful to see some of those resources because I was able to, like, at my annual primary care visit, to look at the blood work that was done, identify that test that you're talking about on my blood panel and say, oh, this is the range that we might expect. Should I send a message to my doctor? And the great thing is you can communicate with your doctor in so many ways now that you can send a quick message to the clinical team. So I know those resources that you mentioned, they've been personally helpful for me and my family members accessing and understanding our health records, but we'll also link to those resources here so that any of our listeners can access them as well. But no, I think that makes a lot of sense. You did mention working with the clinical community. And so BHC has a sister organization, the Midwest Health Initiative, and both the BHC and the Midwest Health Initiative have been partnering with NKF in the development of a quality measure over the last year, year and a half. And this quality measure is, just to put it plainly, is to see if providers are screening for kidney disease when a patient has high blood pressure. And I guess this is a great opportunity to talk about what gap does this fill, how is the measure used, and then how could this lead to improved outcomes for patients? And I think other ways that you are partnering with the clinical community to address some of the challenges you've already mentioned.
Okay, there's quite a few questions there, so I'm going to try
There's a
to work
lot.
my way back through them. So we are absolutely grateful for the collaboration around the quality measure that you now have available in the Midwest Health Initiative looking at CKD testing in hypertension. So we are really grateful for that collaboration. I should point out that about 20% of people that have hypertension will develop chronic kidney disease. So it is a common implication of hypertension, but because it is not as prevalent in hypertension as it is in diabetes, primary care clinicians may not be looking for it. There is also a consideration that many primary care clinicians will only align with preventative services that have a United States Preventative Service Task Force recommendation. And the current USPSTF recommendation does not include hypertension, which can contribute to there being such low rates of testing among people with that diagnosis. Only between 10 and 12% of people with hypertension will actually receive chronic kidney disease testing annually. Why does it matter? One of the things that is important to consider here is the fact that this is asymptomatic. Just like hypertension, it's asymptomatic. And it is a significant complication when it begins to develop. And when you consider the awareness in primary care of the risk of CKD and hypertension versus the risk of CKD and diabetes, you will see that there is an awareness gap that exists that we need to close. Where while awareness of CKD and diabetes is higher, still not great, but it's certainly higher than the awareness of chronic kidney disease and hypertension.
So this may be an opportunity for someone listening or for an employer listening saying, okay, do I have diabetes or do I have hypertension? Maybe at my next primary care visit, I ask about chronic kidney disease. I think that seems like a way that patients can begin to take steps towards advocating for themselves as it relates to this topic.
Well, 100%. If you have empowered health consumers, when I first started working at the National Kidney Foundation, I would often, in my presentations, I would remind everyone that, 30 years ago, you wouldn't say the word breast in mixed company. Never mind have a conversation about breast cancer, which at the time was analogous to what the story is with CKD now. You have a silent progressive disease that is only recognized in the late stages where the outcomes are generally poor and it's ridiculously expensive. So what changed in breast cancer, right? There were a committed group of people, including the employer community, recognizing that there was a terrific public health burden associated with this, and then beginning to empower the community to drive change. So much so that if you're female and you are of a certain age, no matter what doctor you go to, no matter what the care setting is, one of the first questions they're going to ask you is, when was your last mammogram? And so I firmly believe that if we continue to work together, right, and we get the employer community and the payer community and the healthcare community to really understand the impact of undiagnosed chronic kidney disease on patient outcomes, on healthcare outcomes, on employer outcomes, then we'll have that same sort of sea change that will just make chronic kidney disease testing and awareness part of the dialogue and routine standard of care in primary care.
There's one thing you mentioned was the expense and the cost related to treatment. And this CKD isn't something that many BHC employers will see in their top 10 spend conditions. A lot of times it's musculoskeletal and cancer. And so can you give some insight into the cost of treatment for CKD and how this might manifest in those top 10 spend items?
So the first thing I will say, and I used to say this a lot more than I say it now, but you can't measure something you're not tracking. So why is CKD not showing up in your top 10 conditions at the end of the year is because rates of diagnosis are so low that it's impossible to directly tease out the costs associated with kidney disease, except for the small percentage of people who might survive to end stage and the significant cost that's associated with that. So, and the latest number I heard was in an employer population, and this came from a self-insured employer, the annual cost of care for chronic kidney disease is somewhere in the realm of over $200,000 a year when you are in end stage and needing to provide dialysis. So you're not going to see it in your report because the absence of diagnosis makes it impossible to track. The second thing I will say is that because chronic kidney disease manifests as cardiovascular utilization, you will see that cost buried in your diabetes and cardiovascular numbers. What is important to recognize that, okay, you've got those numbers in your balance sheet. That, is what it is. But how effectively is that cardiovascular risk being managed by the providers? How much exposure are you as an employer carrying for those costs that are not being managed because they are not being diagnosed or effectively treated? So I think it's important and maybe incumbent upon organizations, particularly organizations that are self-insured and have an employee population that stays for a while, longitudinal employment, that you consider working with your payer or your organization, TPA, whoever you're working with, to ask for information regarding chronic kidney disease testing and diagnosis in your population. The National Kidney Foundation can help with that. We have a data strategy that we bring to payers routinely, asking them to look at their data for diabetes and hypertension, look to see what percentage of that population is actually has claims data around the two tests for diagnosing CKD, and then look to kind of assess what percentage of people in your population have a CKD diagnosis in their claims data. And chances are you're only going to see those individuals that are very sick. So you're looking at maybe 1% of your population with fully progressed disease, a significant burden of cost, and very little you can do about it. Whereas if you work to identify people sooner, you have an opportunity, particularly if you have longitudinal employees, to bend that curve over time so that there's less of a burden on the organization associated with that elevated cardiovascular risk that is present in the earliest stages of CKD.
I think that's a perfect action step for any of our employers listening. I think as we start to wrap up, Elizabeth, are there any parting words for our audience? Anything you haven't shared that you'd like our listeners to know?
So I think the most important thing I can say is that the National Kidney Foundation is here to help. The team that I have the privilege to lead is focused on what we can do to close these significant gaps that exist for people with kidney disease or at risk for kidney disease and the people who care for them. So there are a number of tools that we can offer. We can work with you on this data strategy to help shape your claims data to ascertain how effectively kidney disease is recognized in your population. We offer patient, consumer education regarding kidney disease if you have a wellness program and are interested in elevating the awareness of risk among your employee population. Would love to have a conversation with you about that. If your organization is geographically bounded, so if you are a school district or a union or an organization that is in a specific geographic area, would love to have a conversation about how we might work together to close the testing gaps and the diagnosis gaps in the community that supports your organization. And so we're here to help. And I think, if the only one thing that's the takeaway from this conversation is that we'd love to have a conversation about how we might be able to work together to close the significant gaps and improve productivity for your team, because it's really hard to maintain employment when you're on dialysis. And then see how we, can't ideally help people have healthier lives and live longer in spite of having a diagnosis of kidney disease.
Well, Elizabeth, thank you so much for sitting down to talk with us today to discuss such an important topic. The resources discussed during today's episode can be found on the podcast landing page on our website at www.stlbhc.org. Thanks for listening to Be Health Connected, empowering healthy workforces one conversation at a time.
Thank you for listening to the Be Health Connected podcast. For additional episodes or to learn more about employer resources available through the St. Louis Area Business Health Coalition, please visit www.stlbhc.org.